don't we just do it at the end? Yeah. Why don't we have everybody speak? Then have just one group Q&A. Yeah. Great. And you can introduce the section and all that stuff. Okay. All right. We're good. This is working. Good. And this is working. Yep. All right, we're good. What time do you have? Okay. All right. We'll start on time. We don't have a lot of people here today. I'm going to go to the beach. My flight's not till tomorrow. My wife and sister-in-law have had a great time without me.
Very good morning and welcome to this first session of the last day, but this is a very interesting session on chronic pancreatitis progression and pain, and there are very well thought of topics have been lined up and we have great speakers, a great lineup of speakers. So the first talk, may I invite Anna Phillips from University of Pittsburgh Medical Center, and she'll be speaking to us on the quantitative sensory testing in chronic pancreatitis. Anna, the stage is yours.
Thank you so much for the kind introduction, and I'd like to thank the organizers and the American Pancreatic Association for the opportunity to present this morning. I've had the opportunity to present a little bit on quantitative sensory testing in the past, so I'm going to talk about a couple of new additional ancillary topics today as relate to this subject. Pain in chronic pancreatitis is the most disabling symptom of the disease, affecting up to 90% of patients over the course of their disease. And there are multiple mechanisms, of course, that contribute to pain in chronic pancreatitis. Among those are inflammation, fibrosis, neuropathy, and ductal obstruction of the main pancreatic duct. Now, patients with known ductal obstruction are often offered invasive treatments for relief of that obstruction, including things like endoscopic therapy, surgical drainage procedures, and even sometimes patients undergo surgical resection procedures for things like inflammatory masses or irreparable damage to other parts of the gland. Also, total pancreatectomy with islet cell autotransplantation is something that is gaining foothold in certain populations. Unfortunately, however, even after optimization of medical therapy and offering of the most invasive, comprehensive therapies that we have to treat this disease, durable pain response still hovers somewhere around 60%. We have tried to identify predictors of outcome to therapy without much continued success. There have been many attempts to do so, but unfortunately, there's not a short list of reliable predictors that we can identify to note patients who are likely to be among those lucky 60%. These three figures are from several specific studies looking at endoscopic and surgical treatment outcomes with regard to pain in chronic pancreatitis. And I raise these figures not to resuscitate the age-old argument over which of the therapies is superior to the other, but rather to highlight the fact that there is something still left wanting. Whether patients get endoscopic therapy or surgical therapy, most patients still have pain after their therapy is complete. There must be something that we're missing. And so here I'd like to highlight a concept, a difference, if you will, between pain and nociception. Now, pain is a subjective and emotional experience that is associated with actual or potential tissue damage. Nociception would refer then to the response of the sensory nervous system to harmful or potentially harmful stimuli. Now, due to the subjective nature and the emotional aspect of pain, a true biomarker development for the measurement of pain itself is unlikely, but biomarkers for nociception or its proxy are possible. And so here, the concept that is central to this talk this morning is central sensitization. Now, this refers to the amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. It results from neuroplastic and neuropathic changes that are occurring in response to persistent visceral and somatic pain stimuli, especially in the setting of chronic pancreatitis. This schematic represents what we think of as the nociceptive continuum in painful chronic pancreatitis, where on the left, you have a patient who is experiencing pain, but processes it in a normal, predictable fashion. As patients move to the right along this spectrum, they may end up with the condition of central sensitization, where essentially these neuropathic and neuroplastic changes have rendered their pain system different. Essentially, their experience of pain is altered. Unfortunately, we have had no clinical tests to date to be able to identify central sensitization. Here enters pancreatic quantitative sensory testing, the goal overall of which is to identify the presence of central sensitization in patients with painful chronic pancreatitis. This refers to a standardized set of stimulations that have been developed, revealing the function of sensory nerves fibers. This technique is tailored for use in patients with chronic pancreatitis, and it's possible because of the spinal cord convergence of visceral and somatic nerves, which facilitates surface testing, actually a proxy testing for the pancreatic viscerotome. So the technique itself is a bit of a leap of faith for most patients, but it involves three very simple devices and processes. One, we use a pinprick stimulator to assess for temporal summation, kind of a wind-up phenomenon. We use a pressure algometer to evaluate for pressure pain detection thresholds. And then we use an ice water bath in conjunction with the pressure algometer to complete a conditioned pain modulation paradigm in order to identify whether descending modulation is intact. Together, the results of these tests allow us to drive patients through this testing algorithm, previously published by my colleague Dr. Fahy in 2021. And so this allows us to phenotype patients into one of three mutually exclusive groups: widespread hyperalgesia, which you see on the lower left; segmental hyperalgesia, suggesting a hyperalgesia that is initiated in the peripancreatic area; or no hyperalgesia, essentially normal pain processing. Now, evaluation of these phenotypes in a cross-sectional manner across a population of patients with painful chronic pancreatitis revealed that approximately 1/4 of patients had evidence of widespread hyperalgesia, just under 1/3 had evidence of segmental hyperalgesia, and the remainder, about half, had normal pain processing. Now, this work has been taken up by a number of colleagues, and I'm very lucky to have excellent collaborators across the world. We currently have 16 sites, actually, and we're still recruiting. So this is work that we're hoping can be widely disseminated in order to help share our findings and also make sure that this is applicable to populations around the world. I'd like to share some of the results of our collaborations, actually, in terms of studies that have been done by a combination of centers so far. And so first, in a set of evaluations done in a cross-sectional manner, we looked here at associations with PQST phenotypes. And what we have seen is that there is a higher percentage of patients with widespread hyperalgesia in the subgroup of patients who have ongoing current pain. We also have seen that constant pain is more prevalent in patients with either segmental or widespread hyperalgesia. We have found that hyperalgesia is more prevalent with higher pain intensity and with higher pain interference. We have also seen that widespread hyperalgesia, suggestive of the presence of central sensitization, is associated with lower quality of life across all evaluated domains. Now, trying to tease apart, actually, many of the different factors that contribute to the pain experience in chronic pancreatitis, this study, published in 2021, had us looking at the prevalence of several different factors which contribute independently to pain. This includes pancreatic duct obstruction, anxiety, depression, catastrophizing, and the presence of hyperalgesia. You see the prevalence here on the left of each of those factors, and on the right, you see their overlapping presence in a population of patients with chronic pancreatitis, suggesting that these things exist together, which is no surprise to anyone. Interestingly, we see that with each additional accumulating factor, there is a linear increase in pain severity that we see, a linear increase in pain interference, and a linear decrease in quality of life as that pain experience gets more complex for these patients. Now, interestingly, also trying to tease apart the presence of comorbid psychiatric issues with pain, we found that with pain resolution, we saw resolution of psychiatric comorbidities. However, hyperalgesia still persists, suggesting that the presence of hyperalgesia itself is not necessarily the problem, but in the context of additional pain, this can make the situation intolerable for patients. And so the cross-sectional information is wonderful, but of course, what is most useful is longitudinal data, trying to understand what will happen to these patients over time when they have developed hyperalgesia. This fueled a pilot study, actually, looking to see if we were able to predict pain response to invasive treatment based on PQST phenotype. In a prospective multicenter pilot study, 3 centers looking at patients with painful chronic pancreatitis who are undergoing PQST phenotyping prior to an invasive treatment, we defined treatment response as a greater than or more than 30% reduction in average pain score. We hypothesized that the presence of supraspinal central sensitization, as evidenced by widespread hyperalgesia PQST phenotype, would render patients less likely to respond to invasive local therapies. And indeed, what we see here is the presence of widespread hyperalgesia is marked by the black bars, and you see a greater density of widespread hyperalgesia patients in those who had a negative response to their invasive therapy, in other words, an increase in pain post-procedure, suggesting indeed that the presence of widespread hyperalgesia is not only likely to render patients less likely to respond to successful therapy, but perhaps even likely to have a worse outcome overall. This pilot data has fueled an appropriately powered clinical trial, actually, the Pancreatic Quantitative Sensory Testing Trial to predict treatment response for pain in chronic pancreatitis, the aim of which is to see whether PQST phenotype can predict pain response to relief of ductal obstruction. This is an NIDDK-sponsored, R01-funded, multi-center clinical trial currently enrolling at 3 sites: Pittsburgh, Johns Hopkins University, and Indiana University. Our aim is to enroll 150 patients total, evenly divided between, sorry for the typo, 3 sites. Here, patients are undergoing clinically indicated invasive intervention to treat ductal obstruction that is painful. And we are planning to follow them up at 3, 6, and 12 months after intervention, with the primary outcome being association of pain change from baseline. And this is measured by a single question numeric rating scale at 6 months after their intervention. I'll just highlight 2 critical inclusion criteria, which are that patients have definitive evidence of chronic pancreatitis with ductal obstruction on cross-sectional imaging, and they have to be undergoing invasive therapy, either endoscopic therapy or a drainage surgery procedure for pain management regarding that ductal obstruction. Now, at the current time, we've just entered year 3 of the study, and here, this is our latest enrollment statistics. We have 44 patients who are well accounted for, and I understand a couple more in the wings already enrolled, and so we're about 1/3 of the way there, and we're hopeful for results here in the next couple of years. Now, one thing is that pancreatic quantitative sensory testing is a wonderful tool, but I will say that it takes a leap of faith on the part of patients to be willing to undergo this, and it takes definitely some energy and maybe occasionally breaking a sweat, depending on the patient's thresholds. And so if there were an easier way to detect central sensitization, I think we'd all be interested in knowing that. And so I just want to highlight briefly, actually, an effort that we've been making at our center to try and identify serum biomarker signatures of central sensitization. And so in collaboration with my colleague, Dr. Jamie Solomon, we've done a pilot study here of 39 patients with definite chronic pancreatitis. And here, using serum samples obtained at enrollment and mesoscale discovery analysis, we're looking for signals, actually, where we might be able to discern the presence of central sensitization among this population. We recruited these patients, and after phenotyping, noted that there were 17 in the population without evidence of hyperalgesia and 22 with hyperalgesia. You can see the rest of the clinical characteristics here. We analyzed 87 different analytes looking at chemokines, neurokines, and different factors that are known to be associated with neural inflammation. And with additional machine learning testing, what you see here actually is one of the principal component analysis results, which is definitely early data, but is suggestive to us that there is at least a signal of potential signatures, different factors that may help us delineate whether or not patients have evidence of central sensitization. And so among these, are things like different interleukins, TNF-alpha, et cetera. And so we're hopeful that this hypothesis-generating work may lead us, actually, to things that might be a little easier to perform than the bedside testing. And so in summary, central sensitization, of course, is the key issue here, and it's suspected to be an important contributor to the pain experience in chronic pancreatitis. The goal here is to identify patients with central sensitization or any kind of precursor that could be leading them in that direction. Phenotyping for this may allow for the prediction of outcome, and our future aim, of course, is therefore to use this for improvement of patient selection for existing therapies, and then to develop new therapies that may directly address this issue in our population. And so with that, I would like to say thank you so much for your attention this morning and for coming. And also I'd like to thank all of these individuals who have just been wonderful collaborators and supporters, and without whom this work could not be completed. Thank you.
We're going to have all of our speakers come up and just remain. We'll have questions at the end. Our next speaker is called The Scoop on Pain in Chronic Pancreatitis, another presentation from Pittsburgh. Leading the way here, Dr. Jamie Solomon.
Thank you. Thank you. It's great that I'm following Dr. Phillips. So she gave a very nice introduction, and I can give you quick points and jump right into the data. So as Dr. Phillips mentioned, I have been welcomed and embraced by the clinical and translational scientists in the pancreatitis field over the last 4 years. And one of the primary collaborations has been to look for other ways to stratify or predict response. So historically, we've had classification systems such as focusing on the pattern, the frequency of painful episodes, or the severity of painful episodes. And we know that there are differences, and not every pancreatitis patient is experiencing pain in the same way. And we know that constant and severe pain are, predictive of poor outcomes and poor quality of life, but that doesn't help us decide how necessarily to choose which is the most appropriate pain management strategy. So as Dr. Phillips just gave this beautiful talk about QST, hopefully that will help us to predict patients that may be more likely to respond to those local invasive therapies, or even other whole body that are not going to respond to those. The patients with central sensitization might be more likely to respond to whole body therapies or neuromodulators. But those are just the treatments that we are helping us classify patients, or specific to the invasive therapies. But what I'm interested in is, can we identify more signaling pathways to target, or specific pathways to target with novel medications, as well as can we predict the response to pharmacological interventions for patients that are not going to go to endoscopic therapy or surgery. So how I've been doing this as a basic scientist is leveraging the data sets and samples available to me through my clinical colleagues. And one of the major studies that we started with was the PROCEED study sponsored by the CPDPC consortium, because not only do they have a lot of clinical data, but we have a lot of data specific to pain, including pain scales, pain patterns, pain medications, and pain quality. And pain quality, what I mean by that is the experience of the pain. So as Dr. Phillips discussed, pain can arise from many different things, including inflammation, injury, neuropathy. And we know that in somatic pain conditions, neuropathic pain and non-neuropathic pain that is just being driven by aberrations in normal nociception are experienced differently. And we believe that pancreatitis, based on the evidence in the literature, includes both somatic and visceral components to the nociception that's underlying the pain experience. So PROMIS pain quality questionnaires, which are part of the PROMIS canons through the NIH, are just 2 5-question questionnaires that are asking about the descriptors of the painful experience. And there's a scoring rubric that allows us to use the cutoff score of 50 to as a surrogate, decide whether the patient is experiencing purely nociceptive pain, purely neuropathic pain, or both. And this is important to understand because at least for the analgesics that we already have, the efficacy can vary depending on whether or not there's a neuropathic component. So in the PROCEED cohort, I'm not sure if the numbers are big enough you can see, but basically we looked at stratifying by who had pain in the last year before enrollment. And then based on these questionnaires, the questions all start with, in the previous 7 days, how is your pain? So then we looked at, of the patients that had pain, who had pain in the previous 7 days, and we were able to stratify that in the pie chart, as you can see, that a large majority, over 40%, fall into the nociceptive only pain category. But we have 32% that fall into this mixed or both, where they have both nociceptive and neuropathic pain. And we even have 5% that seem to have a purely neuropathic pain experience. And when we looked at all of the disease and patient characteristics, they were largely the same among these different classifications, with the exception of diabetes, which had a higher prevalence in the patient that had a neuropathic component or neuropathic only, and pancreatic duct stricture was more prevalent in the nociceptive only group. So how did this relate to the quality of life and other pain features? Of course, all of the subjects with pain had worse quality of life and health than the general healthy population, but we did see a significant difference in all of the categories in that both physical and mental health, as well as different subdomains of quality of life, were worse in patients or subjects that had a neuropathic component. And I'll specifically draw your attention to the bottom 2 lines where we're looking at pain interference and pain intensity were worse when you had a neuropathic component. Okay, so historically, as I mentioned, we classify by pain severity, pain frequency. So when we look at how our pain categories map onto that, I'll draw your attention. There was no difference in the pain medications that people were taking, but whether you looked at severity alone, the frequency alone, or those different individual combinations of whether you had constant, severe, intermittent, plus more severe episodes, etc., we discovered that the nociceptive only pain group was more likely to have moderate and intermittent pain, and the neuropathic only pain group was more likely to have intermittent severe pain on a background of the absence of ongoing pain. Okay, so what does this mean and how can we use this to get at the signaling mechanisms? So we were able to identify a subset of the patients in the PROCEED cohort that at the time of this study had baseline serum samples available. And the bottom line was that we were able to get 300 patients with pain and 57 with no pain. And you can see the breakdown in the bottom of the flow chart of how they broke down into the pain categories. And we used the mesoscale discovery platform, but in this case, instead of doing an unbiased panel, we looked at 19 proteins that have been specifically associated with nociception and pain. And first in this table, hopefully you can see it, but if not, it's just listing the 19 samples. And here we were comparing the subjects with pain and the subjects with no pain. And after adjusting for multiple comparisons, we found one marker, PDGF, which is significantly higher in CP subjects with pain. And in looking at the signaling mechanisms, we find that PDGFB is actually responsible for suppressing endogenous opioid release. So that means that we're inhibiting our own ability to regulate and suppress the pain response. So it's not surprising in that case, in light of that, that patients with pain had higher PDGFB. What about the individual specific pain categories? So of those 19 markers, 5 of them had a p-value of 0.2, and so we carried those into the next phase of the analysis, where we compared each of the categories: no pain, neuropathic, nociceptive, both or mixed, and those unclassified. And after adjusting for multiple comparisons, we found 2 markers were significantly different: TGF-beta1 and GP130. And when we then did multivariate analysis to incorporate these covariates, we found that there was no difference. So the covariates were not influencing this effect. So we now have 2 biomarkers that we know that are different, but we don't know which pain categories. So we performed post hoc multiple comparison analysis. And here on the left, you can see that in the blue box is the nociceptive only group, and TGF-beta1 is significantly higher in the nociceptive group compared to no pain. And when you look at GP130, which is a receptor for interleukin-6, and we've heard a little bit about interleukin-6 throughout the meeting, it's significantly higher in the both mixed pain group compared to all of the non-neuropathic pain groups. The neuropathic pain group was quite small, as you saw, only 5%, and so we didn't have a statistical power to detect differences, but this data would suggest that GP130 might be a biomarker for the neuropathic pain component. As we know from preclinical literature, that if you target either of these signaling pathways, Frank Pareca showed that a small orally available inhibitor of IL-6 pathway is successfully able to inhibit pancreatitis-related pain behaviors. And Jay Pashrika has now had a series of papers showing that if you inhibit the TGF-beta1 signaling pathway, you can reduce that hypersensitization of the neurons, and that you can block or reverse the pain-related behaviors that go with that. And importantly, there's already clinical trials going on for antibodies and small molecule inhibitors and peptides for both of these pathways in other diseases, in other painful diseases, including arthritis, colitis, cancer, Crohn's disease. And in our own pancreatitis group, we have pirfenidone, which can alter TGF-beta, and that trial is in development, and hopefully they'll, in the design, will include pain as one of the outcomes to look at. So this suggests that it is feasible to set up a clinical trial with these drugs, since we already have safety and efficacy data. But pain is dynamic. As we know, it's not constant. Even within one patient, they have different patterns. And so in this PROCEED cohort, we want to know whether pain changes from baseline over the longitudinal data. As Dr. Phillips mentioned, that's the key data that we need. So to begin this endeavor, we started looking at baseline compared to year 1. And this is the flow chart now with our newer cohort with the more subjects included, starting with over 680. And I think one of the most interesting things to point out is that at enrollment, 120 of these subjects had no pain in the year before enrollment. But at year 1, 29% of them developed pain and report having pain during that year between enrollment and year 1. So future studies will have to look at what kind of complications they had or what may account for this. This is just our schematic going down to finding those subjects that had both serum and pain data at year 1, and we ended up with just over 200 subjects. And this is just some preliminary data to show that the dynamics of how there's changing. So these 4 colors are the 4 pain groups, and you can see that they're shifting over the year into different categories, including no pain. And so about half of the subjects in nociceptive only changed and half to see the same. All of the small group of neuropathic pain at baseline changed to some other category. And about half of those with both mixed neuropathic and nociceptive pain changed to something else. And interestingly, those that were unclassified, that their scores on these questionnaires were too low to put into a category, 3/4 of them changed to an actual established category. So future studies are going to delve more into this and look at the longitudinal pain-related changes in the cytokines. And as Dr. Phillips alluded to, I have, thanks to her and Dr. Yadav bringing me into the clinical translational world, I've developed colleagues and collaborations across the country, and we've now obtained funding to look at the pain proteome in the PROCEED cohort, and we're looking at the pain biomarkers in the PQST study with Dr. Phillips, and also in the TP-IAT population with Dr. Melina Bellin. So stay tuned over the next couple of years, and hopefully we'll have a lot more mechanistic data to share with you. And so I just want to acknowledge the clinical research team led by Dr. Yadav and Dr. Phillips, pictured here on the right recently, because none of this research would have been possible without their team or their embracing me as a colleague. And so I really appreciate that. And this is my own lab, and our funding from the NIDDK as well as the National Pancreas Foundation to look at these biomarkers. And of course, the statistical team at CDMC and all of CPDPC Consortium for bringing me into their family. So thank you very much. And I guess we're doing questions at the end. Okay.
Thanks for that great talk, Dr. Salomon. So next, can I call upon Dr. Shaunak Majumdar, my good friend from Mayo Clinic, Rochester, and he'll be speaking to us on the risk assessment and interception strategies in pain for pancreatic cancer and chronic pancreatitis. Shaunak.
Thanks, Rupjyoti, and good morning, everyone. Pancreatic cancer is a lethal disease. It's a dreaded outcome in patients with chronic pancreatitis. So my task here this morning is to shift gears from understanding pain in this disease to understanding what we know about the risk association between chronic pancreatitis and pancreatic cancer, and share with you all some emerging interception strategies. Here are my disclosures. So my learning objectives over the next 15 minutes or so would be to review the association between CP and pancreatic cancer, to assess the limitations of our existing approaches for cancer detection in patients with chronic pancreatitis, and discuss emerging tools for early detection and interception of pancreatic cancer in this cohort of patients. So whenever we are asked a question in medicine to understand the association, we lean on the methodology of a systematic review and meta-analysis. So this is how we started exploring this area. This is work done by Dr. Sonal Gandhi, who was a research fellow at Mayo Clinic and is currently a medicine resident at Mount Sinai. And we did a systematic review of all published literature. The most important point I want to highlight here is being stringent with inclusion-exclusion criteria when we try to assess these relationships. So what we did is we limited the patient's selection of the studies to studies where chronic pancreatitis was defined very definitively using either calcification on a scan with or without main duct dilation or surgical pathology. And the same for a diagnosis of pancreatic cancer. And we excluded studies which relied entirely on diagnostic codes and patient-reported history, because that can often dilute the risk association analysis. And we ended up with 16 studies that looked at the association, cohort studies looking at the association between CP and cancer, and 4 that were looking at hereditary version of CP and its risk with cancer. So what we found is that there's definitely an increased risk of pancreatic cancer in patients with chronic pancreatitis. The standardized incidence ratio was above 20. And when we look at just the subset of patients who had a hereditary etiology, it didn't come as a surprise that the risk in this group was higher. It was approximately 3 times higher than other types of CP. Another important takeaway is when we did a sensitivity analysis, we looked at patients who were diagnosed with cancer at least 2 years out of their diagnosis of CP. This is important because what gets initially diagnosed as CP can be mass-forming chronic pancreatitis, and which is actually pancreatic cancer to start with. So you always want to have a window of time between those two diagnoses to make sure it's not incident cancer at the time of CP diagnosis. And it looked like the risk estimates remain preserved, so this gives us reasonable confidence that there is definitely an increased risk of pancreatic cancer in this cohort of patients. What do we know about hereditary pancreatitis and pancreatic cancer? This is data coming out of the Pittsburgh group who have contributed extensively to this, to the understanding of this. A cohort study of over 207 patients, PRSS1 carriers. And as you can see, the standardized incidence ratio of cancer in this cohort significantly higher than age and sex-matched controls. And what was reported in that particular study is that the cumulative risk of pancreatic cancer at age 70 years was about 7%. This was actually lower than what has been traditionally reported in the literature, where the numbers have been reported to be as high as 40%. And I think it's important to recognize the impact of smoking cessation on the natural history of this disease, and I'll talk about smoking in a little bit more detail later in my talk. But also this particular study included patients both with and without symptoms, and it's important to recognize the association between symptomatic chronic pancreatitis and cancer risk. What about cumulative incidence of pancreatic cancer in CP? This is data that we found in our meta-analysis, that there are multiple studies which report cumulative incidence over time, and there appears to be a gradual increase in incidence with the length of follow-up of the disease. And similar results were demonstrated in a large study based on a VA population that showed that the cumulative incidence rate of pancreatic cancer in CP patients, that's the red line there, increases with time. And so it's reasonable to then say that the cumulative incidence of pancreatic cancer increases with the duration of chronic pancreatitis. Now, what about smoking and pancreatic cancer risk? This is a large multi-ethnic cohort study. It's hot off the press, published by Wendy Stavian's group out of USC last month. Almost 200,000 participants with 2 decades of follow-up and 2,000 patients with pancreatic cancer. What they found is that 50 pack years smoked equals more than 90% increased risk, and every year quit equals to about 9-10% decrease in the excess risk. So that translates to the risk dropping considerably after 10 years of smoking cessation. And what was really interesting is that they demonstrated that if the smoking cessation happens earlier in life, then that has a dramatic impact on the pancreatic cancer risk, because the risk of pancreatic cancer goes up after the 5th decade. So smokers who smoked early in life and quit at an early age, by the time they get to the risk age of pancreatic cancer, that has a significant positive impact. Now, what we don't really have a good understanding of is what is the impact of smoking on pancreatic cancer risk, specifically in patients with chronic pancreatitis. And as you can see in this seminal paper published in JAMA almost 20 years ago here, that noted that if you compare, and this is a cohort of patients with hereditary pancreatitis, you have the ever smokers and the never smokers, and the black dots are cancer cases. Not only is there an increased incidence of cancer in hereditary pancreatitis patients who smoke, but these cancers tend to occur much earlier in life. However, if we look at chronic pancreatitis from non-hereditary causes, this difference is not so obvious. In our meta-analysis, the studies that reported outcomes specifically differentiating between smokers and non-smokers, there didn't appear to be a big difference in the non-hereditary pancreatitis group. So that is, in my opinion, still a slightly unanswered question as to what's the impact of smoking on the risk of pancreatic cancer, specifically in non-HPCP. But what we note in that one study that looked at the amount of smoking, that the risk appears to be higher in a dose-dependent manner. So shifting gears a little bit and trying to understand, are there gland characteristics? So we have been talking about the patient and are there gland characteristics that associate with an increased risk of cancer? This particular study I found really interesting, which looked at multiple factors and tried to predict or find enrichment criteria that increase the risk of pancreas cancer, and noted that a dilated pancreatic duct, so the presence of a prominently dilated duct, appears to be associated with an increased incidence of pancreatic cancer in patients with CP. So maybe long-standing CP with a dilated duct may be the higher risk cohort of patients where we can do targeted cancer interception strategies. However, a missing link in this is we really don't know what the natural history of a dilated main pancreatic duct is in the absence of overt chronic pancreatitis or a visible mass. And I think more work needs to be done to define the natural history of that entity. So what do we have in terms of tools for detecting pancreatic cancer right now? It's primarily on the screening side, endoscopic ultrasound and MRI. And both of these modalities have significant limitations when it comes to finding small cancers in the background of chronic pancreatitis. So if there are colleagues in the room who do endoscopic ultrasound, you'll be able to relate to this image. This is from a patient with chronic pancreatitis, and as you can see, with all the scarring and the calcification and the shadowing, it is very easy to miss a small tumor in a gland that's distorted due to parenchymal changes and calcification. And serum CA19-9, which is an established biomarker of pancreatic cancer, can be falsely elevated in CP. So that brings us to the pancreatic cancer screening status quo in CP. We know there's an increased pancreatic cancer events are infrequent. There are definite limitations of imaging and no established biomarkers. So the current state of pancreatic cancer in chronic pancreatitis is that there's no established and effective screening strategy. The NCCN and several other best practice advisory and guidelines indicate that we should consider screening patients who have a pathogenic or a likely pathogenic germline variant in PRSS1 or the other hereditary pancreatitis genes, and a clinical phenotype consistent with hereditary pancreatitis. And in these patients, cancer screening should start at age 40 years or 20 years after the index onset of clinical pancreatitis, which in some of these patients, they might be experiencing pancreatitis episodes in the first decade of their life. So those patients, we would consider starting screening earlier. And it's still EUS and MRI that's recommended to be used in combination for screening in these patients. And I highlighted some of the limitations of that. There are no guidelines to support screening in non-HP cases of chronic pancreatitis currently. So there are a few emerging diagnostic tools that I think are worth mentioning, and I broadly categorize them as liquid biopsy and imaging. So starting with a blood-based metabolic signature, some of you heard outstanding talk from Julia Merle's group out of Germany earlier in this meeting, talking about a metabolic blood signature and really robust sequential testing and validation in large case control settings, showing really promising data with AUCs greater than 0.9 and higher than 90% sensitivity and specificity as a blood-based biomarker for differentiating CP from ductal adenocarcinoma. We have done some similar work at Mayo Clinic in my lab looking at plasma methylated DNA markers, and here is data showing that a panel of 13 methylated DNA markers combined with CA19-9 has excellent sensitivity and specificity in differentiating patients with pancreatic cancer from control patients. However, there are limitations of blood-based early detection, at least in the field of cell-free DNA and circulating tumor DNA. We have recognized that the ability to detect advanced precancerous lesions or Panin-3s and high-grade dysplasia, we are really unable to do that, and there's lower sensitivity for early-stage disease. So this is the methylation data that I showed earlier. If you look at what happens to sensitivity as the stages get lower and lower, the sensitivity drops and the confidence interval bars widen. So that's really a problem we recognized, and we thought about what alternative modalities can be used, started looking at pancreatic juice biomarkers. The clue is in the term ductal adenocarcinoma, and there are exfoliated neoplastic cells in pancreatic juice. So when we do the EUS screening, can we collect fluid samples and study molecular changes in juice? The first So the way this is collected for the non-gastroenterologists in the room is we pass a small plastic catheter through the tip of the endoscope. It comes out in the small bowel. There is no cannulation of the pancreatic duct required, or we don't need to do an ERCP, so this can be done during standard upper endoscopy. And we collect a small trap at the back end of the endoscope and collect fluid after giving an injection of secretin. And we started looking at this almost 5 years ago with a 3-site Mayo study, case control design with treatment-naive biopsy-confirmed cancers, and we had chronic pancreatitis in the control group. And we demonstrated that there were at least a couple of methylated DNA markers that had significantly higher copy numbers in cancers compared to both normal controls, and as well as disease controls that included chronic pancreatitis. And when we combine a few of these markers into a panel, we reported an AUC of 0.9 for detecting pancreatic cancer. Now, obviously, these numbers were small, and what we did after we published those results was start a prospective independent validation study. So these are results that were presented earlier at meetings this year, and we are in the process of publishing almost 100 cases with cancer and an expanded pool of controls, including chronic pancreatitis. And what we noted is that the same markers that we had reported previously show a clear differentiation between cancer and controls. There is a little bit of an overlap with IPMNs. That's to be expected, as these are dysplastic precursors. But the difference between chronic pancreatitis in blue and the cancers in red is quite notable. And when combining these methylated markers in juice, we report an AUC of 0.87. When we add serum CA19-9, the discriminatory potential goes up further. And for this combination of the methylated markers in pancreatic juice with CA19-9, the specificity was 88% at an 89% sensitivity for all stages, and greater than 80% sensitivity for early stage detection, which is what we are most excited about. We all heard from our colleagues in radiology really fascinating advances in the field of detecting pancreatic cancer on pre-diagnostic scans. This needs to be explored further in the setting of chronic pancreatitis. And this is work that was done by Neil Maria when he was an advanced endoscopy fellow at Mayo, showing that we can really develop these convolutional neural networks on EUS-based imaging as well to detect pancreatic cancer. So to summarize, chronic pancreatitis and pancreatic cancer, what do we know? The highest risk is in hereditary pancreatitis. Incidence increases with disease duration, and a dilated duct may be an enrichment factor for risk. Detecting cancer remains challenging. Screening is only recommended in hereditary pancreatitis, not in other forms. And liquid biopsy and AI-enabled imaging is poised to transform early detection. With that, I'd really like to thank all my members of the Pancreatic Cancer Early Detection Research Team at Mayo Clinic and our funders for their support, and happy to take questions later. Thank you.
Thank you for that excellent discussion. Our last speaker will be Dr. Maya Fogi, Comprehensive Assessment of Chronic Pancreatitis Pain, QST, EEG, and ECG. Okay, it's working.
Good morning, everyone. Today I'm going to talk about comprehensive assessment of chronic pancreatitis pain. Painful chronic pancreatitis affects approximately 80 to 90% of patients associated with lower quality of life and higher rates of disability. Is the primary reason patients seek medical attention. However, mechanism is poorly understood. Pain mechanism in chronic pancreatitis is a complex interplay between peripheral factors, nerve damages in the pancreas, nociceptive signaling that can affect brainstem changes, and also brain changes and structural changes in central nervous system that all will lead in psychosocial impact. Peripheral factors and nociceptive signaling has been previously discussed by Dr. Salmon and Dr. Flips in this session, and I'm going to focus on brain changes in network and brainstem changes in autonomic reaction. This is the perfect assessment tools which is readily not available. But what is available is a modern neuroimaging techniques, such as functional MRI and positron emission tomography that had identified brain region involved in sensory processing of acute and chronic pain. However, these techniques are costly, they are not clinically available, and they have a limited temporal resolution, making it difficult to capture the dynamic nature of pain and perception experience. With the networks, we assess the network, brain network with electroencephalography, for short EEG, which is a technique been around for around a century, been widely used in other neurologic deficits such as seizure and sleep disorders. EEG is non-invasive, easy to perform, cost-effective, and well-tolerated test. It's recorded with very small electrode, surface electrode, which you put on patient's scalp, and despite all this anatomical difficulties such as skull hair and the conductive differences among the patients, still we are getting a perfect and excellent signals from the cortical neurons very close to each electrons. EEG has high temporal resolution that allows better understanding of dynamic pain processing, measure extracellular current by a large spatial scale, reflecting the activity of hundreds of millions of the neurons. EEG waves are named based on their frequency range using Greek numerals. The most commonly studied waveforms are gamma, which represent awareness, beta, which represent alertness, alpha, which represent relaxed status, theta, that represent tiredness, and delta, which is the brain while it's asleep. There are two ways to record EEG. Resting state EEG, very similar to what we are doing with electrocardiogram. A participant is awake but not engaged in any task. This is perfect way to evaluate the functional activity of brain. And we have a stimulus about EEG. This is very similar to treadmill stress test. And we are recording response to specific stimulus. As I shown here, this is an EEG after a cold pressure testing. This provides specific information in a dynamic behavior context, offer insight to how underlying condition can alter temporal pain processing. Enhanced nociceptive response in EEG manifested as abnormally elevated power in theta and gamma oscillation, suggesting that EEG could potentially predict the presence of pain and analgesic response. In many studies, CP pain is associated with alteration in spontaneous brain activity, as been shown in the study with the various resting state EEG data from 16 CP patients with persistent abdominal pain were compared to data from healthy controls matched for age, sex, and education. As you show on the diagram on your right, significant differences in average peak alpha frequency has been shown in frontal, cortical, and parietal and occipital waves, and what is shown, it is particularly significant in parietal and occipital waves regions when compared the patient in control. However, there are limitations to EEG. The scalp EEG electrodes only record compound peripheral neural activities. Evoked potential EEG signals are brief in duration. Sympathovagal balance is measure the brainstem activity. There is a bidirectional interaction with autonomic nervous system and pain, which means pain processing linked to ANS, and autonomic arousal can influence the pain experience. We are using ECG-based assessment to evaluate heart rate variability, which measures the variation in time between each heartbeat, deceleration capacity of heart rate, which quantify the heart ability to slow down or decelerate, periodic repolarization dynamic, which measures variability in heart's electrode repolarization process. Bidirectional interaction between ANS and pain has been shown in functional MRI in several studies, specifically in this one that I'm showing here, that have been shown in 21 subjects during rest and pain. On diagram A, you're seeing the effect of the cold pressure test. with focusing on a heart rate variability. It identified that association between low-frequency HRV and functional connectivity in the areas crucial for autonomic regulation and pain perception, which highlighted an association between autonomic regulation, brain networks, and subjective pain experience. Why is that important? Because there is a role for potential neuromodulation. There are several studies that show beta blockers and alpha agonists has a role in reducing pain, specifically in patients with osteoarthritis and knee pain. Today, the probability of presenting a non-composite, single biomarker capturing pain in its totality is unlikely, and further exploring advanced model to combine multiple objective biomarkers into one composite pain biomarker is essential. Therefore, in Pancreatic Pain Consortium, we joined forces from 16 academic centers from around the world to come up with a study that assessed the activated sensory system with evoked responses, looking at psychosocial modalities, neurophysiological impulses, autonomic system, and serobiomarker as a composite biomarker. We plan for an international, multi-center prospective observational cohort study with aim to enroll 200 CP patients and 50 healthy controls. This is a figure from our unpublished protocol paper that shows that in addition to what Dr. Phillips previously described and we have published and we work on, we are going to add modalities like brain network and autonomic responses with EEG and EKG to the equation. And also we are going to look to see if there is a predictive validity of outcome assessment using all this modality. This is a diagram show that what we are thinking about this biomarker sets. So we are thinking and envision the bedside test, which simultaneously have EEG and EKG recorded in one device. At the same time, we are doing the QSP, QSD as we used to, and we measure all this autonomic system. This has been shown, and we tested the feasibility and technical aspect of this kind of testing with on 19 healthy individuals, and we showed that this was feasible and possible to record EEG and EKG in one amplifier. And to close this, I'm going to show you a little video of what our testing looked like with starring our colleagues from Denmark, Dr. Rasmus Nugger. This is our amplifier. The EEG, as you see, would be connected. And this is the app connected to the amplifier, showing all the signal received. And the EEG cap will be nicely put on a scope from cover ear to ear and from nasal to occiput. This is usually we will prepare the patient beforehand, put on the conductive electric gels on each electrodes, and usual PQSD testing will be performed. EKG also will be connected to left arm, right arm, and left leg, and impedance will measure to see if the connectivity working. There is a trigger point that you can start the recording, stop, and record and save the data on the app. It is very easy to use, the PQSD testing, as we are having the pressure test. It continues, and we are recording 2 minutes of the resting EEG, and then we are having the evoke potential with putting the hand in cold water, and the recording is done. And sorry.
Sorry.
No, it's all right. I just want to thank everybody in the Pancreatic Pain Consortium, especially thank you Dr. Osborne Drews and Dr. Southern Olsen that were not able to join us in this meeting, and also Dr. Phillips and Dr. Yadav that always been great mentors for us, and also all other collaborators in Pancreatic Pain Consortium.
Thank you for that great talk, Maya. You can have a seat and so now I think we can have a couple of quick questions or comments.
Thank you. This has been a wonderful symposium. Minoti Apte from Sydney. I had a question or a comment for Jami, please. You know, in the patients that you followed up for a year, where the pain changed in terms of categories, and maybe I missed it, were there any patients who stopped having pain, and if they did, were their biomarkers changed accordingly?
So yes, there was a small percentage of patients that did go to no pain, and we're right now in the process of analyzing the biomarkers. So we predict that the biomarkers went down, but I haven't finished the analysis yet.
Because I was wondering that, you know, both your biomarkers are profibrogenic, and so I was wondering whether it correlates with anything with either EUS or CT scan fibrosis scores, or whether there's any biopsies available.
That's another excellent question that we'll hopefully be able to answer next year at the next meeting.
Sohail.
Oh, sorry. The questions were in the patients that changed from having pain at enrollment to no pain, what were the morphological changes and the biomarker changes, and that analysis is ongoing.
Sohail.
Yeah, thank you. Excellent talks. You know, I wanted to ask you about the cumulative incidence of pancreatic cancer with hereditary pancreatitis. I was struck by the 7% risk versus the 40%. The Germans had a lower risk. Why the wide variations? Are there epidemiological flaws, or is this just representative of different regions? Because I would think that there are implications for screening as a result of those wide variations.
Yeah, I think excellent question, Sohail. There are several factors that go into these longitudinal kind of cohort studies. One of the biggest challenges is the dropout rate and the length of follow-up into the kind of the older decades of life. So if you have a large proportion of the population that has not been followed beyond a certain age, and all of the cancer events are happening a little earlier, so that can impact the total cumulative incidence. I think that's been brought up in a few papers in the field that there are very few cohorts that have been followed out to the age of 70 years serially over time. So I think that's something important to consider. And lifestyle changes do have an impact on the risk in these patients, but it's still higher than the threshold above which we are screening for pancreas cancer now is about 5%. So, a risk of 7% is higher than what the current accepted thresholds are for screening, but lower than what we previously thought. So that really helps counsel these patients that their eventual survival and their risk of pancreatic cancer is not like, for example, a germline P16 mutation, where the risk really gets up to that 20-30% level. So that's I think an important epidemiologic consideration.
Dr. Rajiv Mehta.
I'm Rajiv from India. My question to anybody. Does it have any impact of an etiology, whether the patient is smoking, alcohol, and idiopathic on the nociception versus neuropathy?
We found no difference.
They are same. So any implication at the treatment part, whether how can we treat we have pregabalin, we have leucosamide, we have preguanil. So any implications with the management part, whether you identify as a nociception versus a neuropathy?
You want me to go first? Okay. So at this point, if there is a neuropathic component, there's more, a little bit more reason to try something like the gabapentinoids or the neuromodulators, like the, antidepressants or tricyclic antidepressants or the SSRIs or even with the sympathetic data, the SNRIs, but we haven't tested that yet in terms of the predictive response. That would have to be like a future clinical trial.
And just to follow up on that, for the panel in general, I mean, this is very complicated, a lot of different types of pain patterns, sensitization, segmentation. Do you envision, once you categorize their pain, there are a group of medications that'll work above for certain categories? Do you have that in your head right now? Because you mentioned some drugs, but as clinicians, when we see these people, if we categorize them in a certain group, are there certain drugs you would use in those categories? Are you envisioning that?
Absolutely. I think that there's a lot of potential for targeted treatment for these patients based on their phenotype. We've already seen in randomized controlled trial data actually that things like pregabalin do help to reduce pain. Pregabalin and antioxidants in addition, have shown in certain patient populations. I think in those early studies, we didn't have phenotype data on what things were contributing to their pain, but absolutely one of the aims would be to develop a targeted treatment strategy from a medical standpoint for these patients at the outset.
Yeah, I think that's going to be the key characterization. So one other follow-up question, is there anything to learn, because your study is going to take years to do, we're going to be looking at this, is there anything to learn or can we do anything with like a celiac plexus block? Someone has chronic pancreatic pain. We know celiac plexus block may or may not help their pain, but just as an initial block to see if the pain gets better or worse, or doesn't change at all, will that give you any information based on what you already know about pancreatic pain? If someone had a celiac plexus block and the pain went away and then came back in a couple of days?
I think the celiac plexus block would take us into a pool of controversy potentially, just given prior conversations, and the general tenor of the field about whether or not to recommend that therapy for patients with chronic pancreatitis. In my personal opinion, I think there may be some value in certain patients to use the celiac plexus blockade as a tool to determine whether or not there is a contribution to their pain experience from a neuropathic issue that is affecting that area.
And that's what I'm getting at. Not that celiac plexus block is a treatment, but can that give us some information on categorizing their type of pain?
Yeah, I just want to add to that I would also predict that the responsiveness to a celiac plexus block would map to Anna's QST phenotypes, in that patients with the widespread central sensitization would not respond to a celiac plexus block. So I think that could be an important thing to look at in the future.
Yeah, I think that's important. It's one of the things I've often thought about, that a celiac plexus block is a visceral block. Right? It's actually getting to the pancreas innervation. And if the pain goes away, then maybe we got something, but if the pain doesn't go away, then maybe there's central sensitization without any proof of that. But I think you guys are going to be able to prove that. And I think practically that may be something that we can get information in the future about when we're seeing patients that come for, a lot of people are still getting EUS and getting blocks and all that to kind of help. So something to think about.
Robert Sutton from Liverpool, United Kingdom. That was a fantastic symposium. Thank you very, very much for all your contributions. There are two areas of comment I'd like to make, if I may, and recognizing that this is incredibly complex. One is the use of opiates, and there hasn't been much comment on that, but clearly it's a vital area, because on the one hand, they are needed in a vast number of patients, but on the other hand, there are so many side effects. And they do contribute to the whole processes that you're describing here, exacerbating them. And some comment on that would be hugely appreciated, because it hasn't really been made and should really be in a symposium such as this. The second area that I would wish to highlight, that I think is really important but is incredibly difficult to address, is the personality and the psychological profile of the individual patient. And when one is with a patient and endeavoring to help a patient with chronic pancreatitis, sometimes it is very obvious, very early on, that their personality is such that they really are going to find it difficult to cope with whatever strategy is adopted to help them. And one feels that, years of counseling even, which is not available in most countries in the world through public services, has to be paid for privately. is possibly going to help a little. So addressing that issue is really difficult, and also you can't really introduce that, certainly in the first few interactions with the patient, because they'll take umbrage. I just wondered if you could comment on that as well, please.
Those are excellent comments. Thank you so much. The first, to address the issue of opioids in the treatment of pain and chronic pancreatitis, is that approximately half of patients in the U.S. are maintained on some type of chronic opioid therapy. I have my colleagues in the Consortium for the Study of Chronic Pancreatitis, Diabetes, and Pancreatic Cancer to thank for data that is currently being analyzed and will hopefully be published soon, exploring patterns of opioid use actually in order to understand that impact upon this patient population. In our initial work actually in cross-sectional studies, we did see an association with opioid use and central sensitization. There's a well-known complication of opioid-induced hyperalgesia that still needs to be teased out in this data. In our early attempts here, we are essentially trying to look at a real-world situation, assessing the presence of hyperalgesia in patients, whether they're using opioids or not, because we would need to start treating from that perspective in the absence of other therapies to treat their pain right now. And so absolutely that's an important thing. I think our aim would be to try and use opioid-sparing strategies in the long term, but I think we're unfortunately a far way away from that. To briefly address the second question about psychiatric comorbidities, again, what an excellent point. Certainly these patients are heavily affected, and there's a high prevalence of both anxiety and depression symptoms in this population. I can say there's an ongoing clinical trial actually, because we know that cognitive behavioral therapy works in these patients. We're trying to make that more accessible and see what the actual impact is, and so I know there are colleagues that are doing that work right now. In our particular cohort, I can address that by saying that our initial nomogram and then cross-sectional data in chronic pancreatitis found that there was not an association between presence of anxiety, depression, and these nociceptive categories. Now, it was a small cohort, and in other subgroups, there's been suggestion that there may be an association between those two, and they may sort together. However, we'll need to do additional work actually to understand how those things interact with one another in our future data.
I'm the Zhenghuan from China. So I asked, it's a very excellent section about the chronic pancreatitis pain. So I have some questions and comments for Anna. Just in our center in China, we always think that half of the patients, they didn't have the painful pancreatitis. So usually in our center, each year about 200 outpatient patients in our outpatient center, and we see a lot of patients, they suffered from the pancreatic calcification and also stone inside. But we just do like the Cambridge 3 or 4 grade, they didn't have a lot of pain. It is what's the significance or what's the important difference between these two countries? Did you do some research about it? This is one question. Another question is about for the central sensitization. We usually, because I'm a surgeon, we always do a lot of work about we think the pain is from the obstruction of the pancreatic duct, something like this, or we do the fry or the big operation for decompress the compression. So we know the central sensitization is about maybe associated with a lot of painkiller drugs about it. So I'm not sure if you compare all of this, because I see your pilot study to compare the ESW and the surgery, and we also know that ISPEC result is that the surgery is better. But I'm not sure if we think painkiller, these drugs should be used more often or not used recently.
Those are great questions. Just to rephrase them, the first question actually was about morphologic differences in an epidemiologic sense between populations in the US or Europe or even India as compared to those in China. One thing that is well known actually is that unfortunately the pain experience does not correlate well with imaging findings in chronic pancreatitis, and so presence of calcifications unfortunately won't tell you whether it's likely that patients would have pain. I think our field suffers right now from a lack of data data from other regions. And so I think that's actually an opportunity that would be ripe for collaboration, is to understand more about the differences in a population of patients, such as in China. The second question that you asked actually is about the use of painkillers, as I understand it, in adjunctive therapy for relief of ductal obstruction, where you're doing surgical therapies for patients who have evidence of pancreatic duct obstruction. And I would say right now, the data that I showed, is well established that patients have some relief, but durable pain relief remains elusive for many patients. And so right now we have few alternatives, and so we need to understand more about what contributes to those patients' experience.
Okay, thank you. So maybe we can do more collaboration, because a lot of Chinese scholars here, we can make more collaboration.
John.
Okay.
Yeah, I'll maybe just add to what Anna just said by bringing attention to the fact that when we see morphological change, I think by default we think that changing the anatomy or addressing the anatomy will improve the pain, but that's not a given. If you look at their data and if you look at the duct stricture data, then actually, the vast majority of those patients had nociceptive pain. So that there's a little bit of a message in there, is that structural morphological changes don't track with pain, and even if something looks pretty overt and obvious, treating that or removing the stone or dilating the stricture may actually not have an impact on the pain as we think. So that's important to counsel patients ahead of some of these invasive therapies.
So quick question for Anna and Jamie. So Jamie, you're talking about neuropathic nociceptive markers, correct? Right? And then Anna, you've got peripheral sensitization, central sensitization, or no pain, right? How do we merge that? Do people that have, I don't want, and then there's also hyperalgesia, so I don't want to get too confused, but people that have central sensitization, do they have nociceptive or neuropathic, or can they have mixed? And the same thing goes for peripheral sensitization.
Okay, so starting off, hyperalgesia is like a phenomenon of when you have a stimulus, an evoked stimulus. So it's not really, it's like a manifestation. It's not really the classification. What we're doing right now with the data set and that Anna's enrolling is trying to see if there is an overlap of how, just like we did with frequency and severity, of how these pain categories map onto central sensitization. So they're not mutually exclusive. Okay. There's probably not going to be a linear overlap either.
So what you're saying is someone can have central sensitization and have neuropathic and nociceptive pain markers? Yes. Great. Yeah. Okay. I'm just trying to...
Yep, exactly.
Right. Great. All right.
John from University of Florida. I had a question to Dr. Solomon. So basically, is there like a correlation between the pain scores and the fibrosis severity, like markers like TGF-beta in moderate to severe disease? And the second part of the question is like a follow-up to what Dr. Apte asked about in the advanced disease, like what changes, like the advanced patients with painless advanced chronic pancreatitis, what are the markers which you see? In the PROCEED cohort.
So in the PROCEED cohort, we didn't see any correlation between fibrosis and any of the pain features that we looked at. In terms of the severity of the pancreatitis, I'm not sure that we have just one endpoint that covers that whole thing. So we did look at things like calcification or duct dilation or atrophy, and there was no significant difference between the different types of pain. I do want to emphasize that we use the term like neuropathic pain or nociceptive pain, but we didn't have a clinical test to make that classification. It's based upon the patient-reported outcome. So that is just a caveat to think about. Whereas in, like a somatic pain condition, you can do an MRI and see that the nerve is compressed. We don't have resolution at that imaging level yet to see that the nerve terminals in the pancreas are crushed or degraded until you take it out and do histological analysis. So that's a unfortunate limitation that we have at this point.
Thank you.
So I just wanted to follow up on the comment that Sohail made with regard to the incidence of pancreas cancer and hereditary pancreatitis. So if you go back to Dr. Lowenfeld's paper, although the point estimate is 40%, but if you look at confidence interval, it goes from like 3 to 70. So there is a very wide confidence interval that is reflective of the small sample size of the total cohort they had. That's one. And Shaunak mentioned in terms of, so that was a tertiary care population where patients are presenting with symptoms, and now you're looking at cancer in those patients. The difference in the HP study that we did from Pittsburgh was patients who came in to get tested for HP, and there was a very wide in terms of clinical manifestations that these patients had. And they were followed in an unbiased manner through registries and so on for a very long period of time. So that kind of reflects a more true estimate of pancreas cancer in these patients. The other possibility that we discussed in the paper was, if you look at smoking in the general population in the US, that has dramatically gone down over 30, 35 years. So Dr. Lowenfeld's cohort was before 2000, and these were patients actually who were followed until 2015 or so. So some of these things can explain the differences in the estimates, but the confidence interval in our study population was much, much tighter compared to what was there. But from a management standpoint, I think the important point here is that if you have a patient with chronic pancreatitis, the thing that you can counsel them is do not smoke, because smoking plus chronic pancreatitis in general increases the risk of cancer. But if you have a PRSS1 patient, there the risk would be dramatically higher.
I think one of the things that's very striking, and I want to get more opinion from the group, is that the pain appears to change. And once you get to the point where you have categorizations of pain and medications that may work for certain pain features, we may have to change the medication that we're giving that same patient because their pain pattern has changed. We may have to repeat the QST and see how the pain changes. And it may or may not be related to intervention.
I think it'll absolutely be related to intervention. You're not going to have a patient that comes in, you prescribe something, you fix the pain, and then they're good for the rest of their disease. It's absolutely going to be an ongoing where you're going to have to change, switch things up. And similar when you think about someone who gets like opioid tolerance or something and you have to change it, I think this is something that will be an ongoing monitoring.
Yeah, good morning. I'm Jens from AbbVie. First of all, I want to make a comment and congratulate you and obviously APA from what we have seen emerging as a really important topic for chronic pancreatitis patients, which is the pain, and trying to address the pain and characterize it. And you have gone long ways, and we see now the fruits of the consortium. So I want to thank you for sharing that and doing this. And then I wanted to ask you a little bit of a question on some of the data you now show, which has to do with biomarkers. You're coming up with trying to characterize pain by itself, but also what it's linked to, what you see. And one of the biomarkers you have looked at is TGF-beta, which came up. And certainly that's a very hot topic in terms of, are you looking at it simply as a marker, or are you looking at it potentially as a friend or foe of the pain, you're looking at? And I'm saying this because we know TGF-beta has so many roles. I mean, in chronic pancreatitis, the laydown of collagen, the differentiation of fibroblasts. In the pancreas by itself, it's in the macrophage infiltration and production of the cytokine there certainly contributes to the fibrosis, but it also contributes, as we know, to repair, peripheral repair of neurons or nerval damage. And then the central nervous system, as you point out, centralized pain. It would be important to sort of differentiate also these roles of TGF-beta maybe in the periphery and in the central nervous system. And I wonder whether you can comment on it, where you see TGF-beta's role when you identify it as a biomarker, and then in terms of as a potential target or simply a marker of the different types of pain.
Oh, I think it's absolutely going to be a therapeutic target, and hopefully it can be like a dual hit target, because so far it's like all of the data that I'm aware of is that TGF-beta is bad, and it is both pro-fibrotic, pro-inflammatory, pro-nociceptive. So if that bears out to be true, blocking those signaling pathways, could impact all of those pathways and help disease as well as the quality of life of the patients. Of course, there's different receptors and different sources of TGF-beta, and so if it turns out that they are not all, a positive or all negative direction, then we have to start, designing drugs that will target the receptor as opposed to the ligand or cell type specific, but I don't think that there's enough evidence to suggest that's necessary quite yet.
So, since you're running short of time, one quick question to Anna. So this PQST thing you are doing a global level, 16 centers, more centers are coming up. So there could be many other parameters or confounders that could bias or skew the results. So how do you propose to harmonize the data from the global center so that we have one cutoff all across?
That's an excellent question, just because certainly we've seen differences in different populations. The data that we have right now is heavily Western, in the sense that most patients that have been tested are from the US or Europe. There's a large Indian cohort that I know you're aware of. And so I think the most important thing is for each new geographic region actually to repeat nomogram data in that area to make sure that indeed normal values look similar across regions and populations. I think that can help us best accommodate then any differences we might see in general populations before we start to make adjustments for threshold values in the testing as it remains standardized across populations.
Thank you. So before we break, there's a quick housekeeping announcement. So all these sessions will be available for the next 3 months, the recordings in the meeting app, and will be online. And if there are no questions, I think we can close the session. Thanks for the great talk and participation.